So welcome everyone to this webinar, Let's Code Together. My name's Jane Knight and I'm a clinical associate with the Medra MSSO, and I'm joined today by my colleague Dr. Carol Ann Wilson. So
hello and welcome everyone.
Together we're going to take you through the next hour and a half. We're going to do some coding examples and we'd like to make the session as interactive as possible. So we can't have face-to-face classes at the moment, so this is the next best thing. We've tried to make it in a workshop format. So throughout the session, you can comment, you can tell us your thoughts on the examples using the questions or chat panel, and we'll come back to you that way. We'll share your questions with the group and have a discussion on certain ways of doing the coding. The first slide we have today just explains that Medra came around in the mid-1990s and it was an ICH initiative. At the time, the MSSO was put in place to maintain and distribute Medra, and the activities of the MSSO are overseen by a management committee with representatives from the industry and the regulatory authorities across the ICH regions. The next slide is a copyright notice explaining that Medra is owned by ICH, as is the material that we're going to use today. And if you choose to use any of the material in any way, you must acknowledge ICH as owners of Medra and of the material. So I've explained that we'd like to make this participative, and so we're urging you to use the questions panel on the right-hand side to ask questions or to comment. Sometimes it may be that we don't all agree on the right answer, and in the interest of time, respect to everyone, we need to agree to disagree. We can't take requests to code specific verbatim terms today via the questions, but at the end there will be an opportunity for you to propose examples for us to take forward and consider for future sessions. And this is how we've got a number of the examples we've got today, that they have been proposed real-life examples from other attendees in the past. We do these sessions monthly, so we can't guarantee when we'll do your topic, but it'll be something that we'll work on to incorporate into a theme for future. This is what I mean by the interactive polling. So this is Poll Everywhere, the application that we use, and you can access it using an internet browser, either on your computer or on your cell phone. So you need to open an internet browsing session, and into the URL field, you type pollev.com, and then it'll ask you for a username. So it's completely anonymous. You don't need to put your name in. And in order to link up to our presentation today, you have to enter my name. So Jane Knight 855, that's the username, Jane Knight 855. And then you click join and you will be linked to the presentation. If you forget that, if you have a look in the chat, the details are there. So if you don't have time to complete it now, before we move on, you can get it from there. So let's have a look. Where are we in the world today? I see some of you are there already. Someone from Russia, UK, like me, and then across United States. Very good. Not many of you today. It's quite a small group. So do take this opportunity of asking questions, making comments, and we can discuss. Welcome. Wherever you are in the world, welcome. So we've made available for you a demo of the web-based browser. You may have your own credentials to hand that you can use for the session, and that's fine if you want to use your own credentials. But we also have for you here a training account with a password that will be valid just until Friday of this week. You can access the web-based browser from the homepage of the Medra website. And if you click on the WBB link at top right-hand corner, enter those credentials. And again, if you forget them, they'll be in the chat for you. You don't have to use it. It's just if you need access to a browser. So just introductory, we would say when we code, there's not always an exact match, and that's what makes these sessions interesting. Sometimes there's more than one possible approach, and we may have differences of opinion in how to code something. Even the points to consider documents sometimes offers us options, alternate handling of reported events. Sometimes it may be that we understand the term differently. Sometimes when we prepare, Carol Ann and I will have different understanding of a certain verbatim. And so what we do whenever we code, the way we would describe it is we're looking for the closest LLT match or to find a best approximation. Overall, we always code as reported with no assumptions. And this is what it sometimes feels like. In all our sessions, we have a picture like this. And the point we're trying to make is who's to say who's wrong? If I were to say I'm seeing a fruit stall there, and I can see all the fruit and vegetables. And then when you look more closely, you can see that there's a person lying down across the shelf. Now, who's to say what's right and wrong? And sometimes verbatim terms are like that. You see it and you think you know what the term is referring to. But when you look more closely, you see that there's something more to it. It's not quite as straightforward. So it's about medical judgment, a balance between applying the coding conventions, coding rules for consistency, but also applying your own medical judgment. And that allows us to keep consistent, but also manage risk to patients. Medical references are helpful, and you'll see we use references today in the way we explain our rationale. Sometimes it's there you can't find a term in MEDRA for the concept, and you have to request that a new term is added to a later release. So having said all that, I'm going to just give you a wave, switch my camera off because I find it distracting, and we will get on. Let's code together. So I'll hand over to you, Caroline, for the first one today.
Yes, let me share my screen. Here we are. Switch off my camera. So here's the first example. It is reported that the patient felt all wiped up, something that you would rather see in post-marketing reporting. So can this be directly coded, or are there LLTs which would match the verbatim, or can we identify appropriate synonyms, or do we need to query? What do you think is meant here with the verbatim felt all wiped up? What does the reporter mean by felt like all wiped up? Fatigue, yeah, would be one option. Worn out. Somebody would query, need query for clarification. Tiredness, all grouped under fatigue, fatigue extreme. Query. So most of you are voting for fatigue or an LLT under PT fatigue. Wiped out, washed out. Perfect. Exhaustion, also grouped under PT fatigue. Okay, and based on your understanding of this verbatim, how would you handle this report? So would you code based on your own understanding of the event, or would you, how many of you would really seek clarification from the reporter? So it seems that many of you have an own understanding of the event, but the majority would rather prefer to seek clarification from the reporter. Now let us browse MEDRA to see what we can find in MEDRA. I have to log in again. Kick me out. Here we are. And if I just enter wipe and search, I have no hit. So there's nothing that would really be a direct match to our reported verbatim. So we will have to look for a synonym for some approximation to what is reported here. It is a feeling, so it's a subjective feeling that is reported and not a sensory disturbance in the neurological sense. So for that, I would rather look into the general disorders SOC, and here the most appropriate HLGT would be general system disorders, and you see that we have an HLT here that is named Feelings and Sensations NEC. And in this HLT, you see the feeling abnormal PT with many LLTs underneath, like feeling lifeless or feeling abnormal, weird feeling, spaced out, floating feeling, etc., etc. So this would be one option, because what was reported is a feeling. But let's look at the asthenic conditions as well. Same, also grouped under the general system disorders, NEC. And here we have the fatigue, PT fatigue, and many of you have chosen LLTs under this PT, like exhaustion, fatigue, but also washed out, weariness, worn out. So this would also nicely represent our reported condition, but does not contain the information that it's just a feeling. Let me switch back to my presentation here. So here again, the screenshots of what we just saw. It is really not easy to decide which LLT would best represent our verbatim, whether it would be one from PT fatigue, or whether it would be more appropriate to select an LLT from PT feeling abnormal, like either the one that is identical to the PT name, or, for instance, feeling lifeless. I think that we can all agree that this verbatim is really vague and ambiguous, and it is really not fully clear what is meant by felt like all wiped up, especially when considering that in drug safety cases, events are often reported in local lay language and then translated into English by non-native speakers in local drug safety units. So it would be advisable to query to find out what is exactly meant by this verbatim. But if you work in post-marketing and drug safety units, you will be aware that very often one will not be able to get useful additional information. So you may then look for any additional information in the case itself to better understand the medical background. And if that is not possible or does not help any further, then you will have to look for vague terms which could best represent the concept, so the best approximation to this verbatim. And the final suggestion for this verbatim is to first try to query, of course, but if no useful follow-up information can be obtained, then assign either feeling abnormal, capturing the fact that this is a feeling, or LLT washed out under PT fatigue. That would be our suggestions. Any questions, Jane?
No, there's no questions. There's just a few comments that people agree with you. Their first thought is that this should be queried.
Yeah. So we will now address several examples that relate to neurological disorders. Here it is reported that a patient suffers headaches in cold weather. So is this verbatim now clear enough and unambiguous? And what is the basic medical concept that is reported here? Is it important to capture the cold weather as well, or can we ignore this information when coding? What do you think? How would you code this event? Would you code this to cold stimulus headache, to cold intolerance, to cold dysesthesia, just to headache? Or would you split code and code to headache and exposure to cold temperature? I see that the vast majority is really going for cold stimulus headache. And I would fully agree here. So let me show again how to search this. If we would only look for headache, here it is, and search, we would of course get a direct match in Medra, right mouse click, go to browser, and we would be able to explore the LLT content of this PT. But there's nothing that would, there's a drug-induced headache, chronic, but there's nothing that would relate to cold temperatures. So, but if I add the information cold and search again, then I will find cold stimulus headache. And you will see that this it's a medical concept, separate medical concept, has its own PT, and it's grouped under the same HLT, that is headaches, NEC. And you see that there's another LLT, ice cream headache, because cold stimulus headache is often named ice cream headache. So it's a specific medical concept, and it manifests as a short, sharp pain in the forehead after eating or drinking or inhaling something cold. And it can also occur when suddenly exposing the unprotected head to cold temperature, such as in cold weather, as reported in our verbatim, or by diving into cold water, for instance. So what can we learn from looking at this verbatim? First, try to capture as much of the information as possible. Don't stop when finding LLT headache, but look for more specific terms that would also capture the reported specific subtype of headache. So look for a combination term. But always stay as close to the verbatim as possible, code as reported, the basic MEDRA coding rule. Do not add information by coding to an LLT like cold dysesthesia. That was one option in the previous poll. Always keep the actual reported term in mind if an LLT looks suitable. What was reported here was a specific type of headache, not a dysesthesia or cold intolerance. With this, the final suggestion for the coding is cold stimulus headache, which is grouped under the same PT here, LLT cold stimulus headache. Your turn again, Jane. I hand it over to you.
There's no questions on that one, Caroline. Thank you.
Okay. Seems to be clear. It's quite straightforward.
So our next example is nerve pain due to whiplash. Oh, let me see where I'm. Have I shared my, no, let's try again, There we go, that's better. Nerve pain due to whiplash when travelling on a bus which stopped abruptly. So again, we ask ourselves the same questions. Is the verbatim clear enough? Or is this something, so we've got nerve pain and we've got a whiplash injury really, which happened accidentally. So is there some kind of combination term, or do we need to capture both parts of this? Do we need to split code, and do we need to query? Well, I don't think there's any point in querying there. We're not going to get much more. But is nerve pain part of the whiplash? Or when it says nerve pain due to an injury, this could be some period of time later. So my brain would be thinking about the PTC guide where it talks about signs and symptoms and diagnoses, but I don't think that would apply here because we've got the following on, a consequence, a sequela of the injury. So I would be looking to either split code or find a combination. So what would you do with this one? What would you code it to? You have a look in the browser and see what you would select. Nerve root compression and nerve pain. Nerve pain, so we've got some commonality there. Whiplash injury, yes, well that's important to capture, isn't it? Because that's the cause of everything. Whiplash injury and nerve pain, so there's a split. Whiplash injury, nerve pain, whiplash, nerve pain and whiplash. So nerve root compression is an interesting one. That's the one that seems a bit different there. I would be cautious about choosing anything that seems that I'm interpreting or diagnosing or looking more deeply into it. That may well have happened, but that's not what we've got reported. So I would be looking to capture what has been reported. So the whiplash injury and some way of capturing the nerve pain. And if it's possible to find a link between them, somebody there is looking for suggesting pain trauma activated. So that's an interesting one. The kind of term we'd be looking for some relationship, if possible, between the nerve pain and the injury. So let's go and see what's in our browser. I don't think I've got my browser open today, so we'll open our browser and see what we've got. So looking to capture the whiplash injury and then the nerve pain. So the whiplash hopefully should be, all of you had suggestions, so let's have a look. Whiplash is the first one, whiplash injury or whiplash injury to neck. And if we look at the hierarchy, we look at the PT for both of those, they link to the same PT. Post-traumatic neck syndrome is the PT for it. We can go to the browser. There it's multi-axial. And there it is. Post-traumatic neck syndrome has a number of LLTs underneath it, including whiplash injury and whiplash injury to neck. So I would go with what's been reported, whiplash injury. That's the best for the whiplash. But what now about our nerve pain? So is there a way of capturing nerve pain which is related to the injury? So we've got an LLT of nerve pain. We can look, and the PT for that is neuralgia. But that, and if I put my cursor on it, I can see on the right-hand side the sock, it'll be in the nervous system disorders. So neuralgia. So there isn't any other kind of post-traumatic nerve pain. Let's have a look if neuralgia, if that's the wording that Medra prefers. Let's have a look at neuralgia and see if we've got something which might have a post. Well, let's even enter post in here, make it easier for ourselves. Post-traumatic as well, and there it is. There is one, post-traumatic neuralgia. So that's the one that really captures the nerve pain and the relationship to the injury. So we can't get a combination term for the whiplash with the pain, but we can code the whiplash and then the neuralgia, whether it was immediately after or some period of time later. Post-traumatic neuralgia. That's what I would be looking to select. So let's go back to our slides. So the learning points here is that we do need to capture all the reported information. Look for combination terms if you can. Consider the points to consider, as I always do. And I'm thinking, well, do I need to capture both parts? Yes, in this case, you do. The points to consider tells you, although with signs and symptoms, the preferred approach is just to code the diagnosis. When you have a chain of events, it's important to capture everything in that chain. And particularly here with the nerve pain, it's possible to capture the traumatic cause. So that's what I would do on those two. Final suggestions, as we saw, was the LLT of whiplash injury and the LLT of post-traumatic neuralgia. If you've got any comments, you can type them in and give your thoughts on that one.
Yeah, there's one comment, Jane. Since it says due to, wouldn't it fall under symptom of diagnosis rule from Catherine?
I don't think I would do that. In the points to consider, it says that if there's more clinical information, then it's always sensible to split. And the reasons why I decided not to do that was because it does say due to, so we know it's caused by that, but is it immediate? It might be a period of time later that the nerve pain occurs. And also the other reason was when I did do some research on whiplash, and whiplash does cause neck pain, but because it's so specifically reported as nerve pain, that was when I decided that it was better to capture it separately, because it could be that something has happened. One of the groups said maybe there's some nerve root compression. We don't know what's happened. So there may be more injury in there beyond a simple whiplash injury. So this is why I decided to code the nerve pain separately.
Another one, do you code the bus accident in addition? From Jackie.
Yeah, well, if it was the bus driver and there was something that I might be thinking, does our drug cause impaired driving ability? Then, and it was within the control of the patient, if my patient was involved, then I would maybe think about, yes, I would code some kind of road traffic accident, bus accident, whatever the closest is. But because it's a passenger on a bus, I'm not sure that I would. There's nothing to stop you doing it if you feel you want to capture that as well. But I personally, I didn't see that there was any relationship between potentially the patient being involved in causing the accident. What do you think, Caroline, on that one?
Yeah. Yes, I agree. So it's just it's a victim of this accident. The patient is not directly involved, has of course the consequences of has to suffer the consequences of this accident, but is not directly involved.
Yes, I mean, there's nothing to stop you if you're working in drug safety. You could, but that's my feeling. So our next one, The next one was reported like this. This isn't a verbatim that we've actually taken, and it was reported as oversensitivity on the left side of face, left limbs, and the left side of the body. Now, seeing that oversensitivity, what does that mean? So I think of hyper for over, but if I put hyper there, it would have a completely different meaning. It would have an allergic hypersensitivity, and that would make me think of allergic reaction. And that would be a bit strange, saying it's on the left side of the face, the limbs, and the left side of the body. Being like that down one complete side of the body, I think about probably more of a neurological problem or more of a skin sensitivity. But in it, again, the question we ask ourselves, is the verbatim clear enough to code? What does oversensitivity mean? Does it mean hypersensitivity and they've got some kind of rash? But it would be strange having it completely down one side. Is the left-sided location relevant? Well, potentially, yes, if we are looking at some kind of neurological disorder. And then do we need to query? Is there any value in querying? What can we do with it? Well, we've looked at the browser ahead of time on this one, and we've given you a few LLTs there to choose from. Here are a few. So we've got an abnormal physical sensation, or if we'd say it's down one side of the body, is it a disturbance of skin sensation? Is it increased skin sensitivity, oversensitivity? Is it an increased skin sensitivity or a false sensation? Hypersensation, skin, hypersensitivity, or hemi-hyperesthesia? What do you think there? I see it's unstable. I think everyone's voted that's going to, I think. Oh, a few more. Get your votes in now. And I'll show you where the audience is leaning. So most of you are going for hemi-hyperesthesia. Some of you are changing your mind. That's cheating. I'm going to close the poll and we'll see. I'll lock it there. So hemi-hyperesthesia, I see that that's the number one choice, which seems like hemi, meaning one side of the body. That looks good. And hyperesthesia, increased sensation. So let's have a look and see where these terms lie. So I'm going to look up sensitivity first. Start with the reported words, sensitivity. And there we go. I've got 139. So, oh, that's a lot, isn't it? Well, one of the terms we had there was skin. So let's start with that and we can browse around. Combination of top down and bottom up. Let's start with skin sensitivity. So we've got increased skin sensitivity, oversensitivity on one side of the body. And let's go to the browser and look at that one, the placement of it. And I see immediately there, before we even get in the hierarchy, we can see the PT for it is increased skin sensitivity, has a PT of hyperesthesia, increased sensitivity, increased sensation. We can see any others there. So that seems like quite a nice one. And if we look, as some of you chose in the multiple choice, you see here the other term that I gave you to choose from, hemi-hyperesthesia. And that one makes a lot more sense when you see the link between the LLT of increased skin sensitivity, the PT of hyperesthesia, and actually by looking in the hierarchy here, we're able to see that there is something even closer, hemi-hyperesthesia. And I'm quite comfortable, I'm quite happy to choose that. It doesn't just say the left leg, it says the whole left side of the body, face, arm, whole left side. So hemi-hyperesthesia, I think, seems a pretty good match to me on that one. So let's go back to our slides. And this just to remind you here, to show you there, the two PTs side by side, they both fall within the same HLT, hyperesthesia and hemi-hyperesthesia. So our learning points there is that I do look to code as reported and I search using the reported words. So sensitivity would be my first go-to search. I would look for use medical judgment, thinking, well, one side of the body probably makes me think of some neurological context. If I was unsure, you can always query if you want to. I know in drug safety you can't always get a clarification, but ideally we would if we were unsure. And there I would consider that the report may have originated in another language. So depending upon the other information provided, it may have meant hypersensitivity. So for example, if it had just said oversensitivity on left arm or something, I might have thought, well, do they mean hypersensitivity? Has it been badly translated? So those are some thoughts there. And our final suggestion to sum up is hemihyperesthesia. Well done, those of you who voted for that in the quiz. Any comments on that one, Carol-Ann?
No, no more comments.
Thank you. So this one, we're moving on now. We've got, this one was called, it is reported as an end-of-life care for a 95-year-old man who is confused, persistently crying, trying to get out of bed, which is upsetting his daughter. Therapy was changed because his agitation is uncontrolled by morphine or sedatives. So what is being reported here? There's a number of things being reported. He's in end-of-life care. He's got symptoms of confusion, persistently crying and trying to get out of bed. And that's, they described there as agitation. Then his therapy was changed. So what do we need to code out of all that? And is there any point to query? Well, again, I wouldn't query that one. I would look to break it down and find the individual terms to capture. So what would you do here? Oh, we've got, I'm not sure what's, I'm back on whiplash. What's happened to this one?
That's strange.
Let's go and browse. That's strange. This, if you've got the poll open, maybe you can check it on mine. We're back on our whiplash, aren't we?
Yeah.
It's active. Passenger in a motor vehicle accident. Terminal agitation. Here we are. We're getting them now. Terminal agitation. Persistent crying. Terminal agitation again. So you've taken the words that you were given. So end-of-life care, a number of you have looked and you've looked for agitation and found the term terminal agitation, which would seem to capture it, wouldn't it, for end-of-life care? Oh, we've got a bit of a mix. So let's go and have a look in the browser and see hospice care. Therapy changed. Yes, that's right. That was reported as well, wasn't it? Is hospice care in Medra? Is there an equivalent? You would split it out. So let's go and do that. Let's go into the browser now and have a look and split them out. So the first one we had was confusion. Well, that one's going to be easy to find, isn't it? He was confused. So let's use the exact word. Confused. There it is. The LLT confused with a PT of confusional state. And again, we can go to the browser and see a number of different ways of expressing it. Confused, confusion, confusional state. Always good practice to look at the LLTs there. Confusion state. And the crying. And somebody said they'd found persistent crying. I think you found it, or you were just taking it from the report. So persistent crying, when I search for crying, I see there persistent crying has the PT of crying. That's probably one used, majority often used for children, I would think, when somebody reports that children are persistently crying. Crying here, babies, crying with the inconsolable persistence. We're able to capture the words from the report, persistent crying. And then we've got the agitation. We're trying to get out of bed. I would probably take that as captured with the agitation. If I can code agitation, that would sum it up really, wouldn't it? So, and this is the one that some of you found, terminal agitation. It has its own PT and it's something which can affect people at the end of life where they are just not long left. Terminal agitation. So that seems like a good one. And remember, the care is in end-of-life care. So can we capture that as a procedure? I can click on surgical medical procedures to limit it and see if there's any kind. Somebody suggested hospice care. So let's have a look at care and see what we can get. 24 terms there. We've got hospice care. Yes, is one of them you suggested. End of life. You might call that hospice care. I might call that palliative care. That's the one that I was thinking, palliative care, but very similar there. supportive care and palliative or hospice, one of those, whichever you think best fits with your opinion. And then we've got our therapy changed. So let's have a look at that one. Therapy changed. Oh, 747. We don't want to be looking at those. Let's put change as well. Therapy changed. Therapy changed. Drug therapy changed is an LLT. Nice one there with a PT of therapy change. And nobody mentioned it here. When we gave this session this morning, somebody suggested, should we be capturing that the drug is ineffective because the therapy was changed? And we decided, if I go back to the slides, you'll see what I mean. The therapy was changed. We don't know why we're reporting. We don't know at this stage what is our drug, what's the suspect drug. We don't know why we're capturing it. So unless I knew that my drug was related to that morphine or one of the sedatives, I wouldn't really be looking to code the lack of drug effect. But it is there within the case, but I don't think it's relevant to what we would be entering. So I would look to capture all the symptoms and maybe look for synonyms of that. So we saw that with end of life being either palliative care or hospice care, agitation, terminal agitation in the context of the report. And these are the terms that we found. So if you've got thoughts or comments on that, please do let us know and we can have a chat about it. So I'll hand back to you, Caroline.
Catherine is asking, is confusion part of the terminal agitation?
I didn't see it as such. I saw them as being different. They're reported separately. Confusion, agitation, I think, as being more of a physical, observable thing, whereas confusion, yes, you can observe it, but it's also an internal. So I thought it was relevant to capture them separately. I don't see terminal agitation as being a diagnosis for the other symptoms.
Yeah. So then, thank you, Jane. I will now make myself presenter again. Here I am. In this example, we are told that the patient was rebellious about everything and refusing to take the medication. Again, we first have to decide whether this verbatim is clear enough to code or if we need to query. And if we find that it's clear enough, then if we do not find a term for being rebellious, what would be the synonyms that we could use? What would be the best approximation we could find? So what LLTs would you select for this verbatim, rebellious about everything? For the rebellious attitude, what would you select? Defiant behavior? Yeah, the refusal of treatment by patient must be coded. That's the second part of the information that was provided. Aggressiveness, defiant behavior. So defiant behavior rather relates to uncooperative behavior. We have more information here. We know that this is due to the fact that the patient has a rebellious attitude, combative, also something that is rather to be considered an aggressive behavior. Angry. So we have different opinions here. Now let us check what we can find in MedDRA. So many of you have pointed at the PT aggression, where you can find LLTs like argumentativeness, challenging attitude, combative reaction, or also quarrelsomeness. So argumentativeness describes personalities who show a tendency to disagree or argue with other people, but rather in an angry way. So the quarrelsome person is somebody who likes to dispute, who shows a more confrontational attitude. So But are we told that our patient here really has an aggressive attitude? We are just told that he has a rebellious attitude. So what would be the other options? Defiant behavior. As well, you have proposed this, but as I said, it's rather describing an uncooperative behavior. And then we have another PT that is negativism. And here we have the LLT oppositional. So this would be a nice term because it seems to be suitable, describing an attitude marked by skepticism, especially about nearly everything affirmed by others. What we could easily see is that deviations of attitude and behavior are not easy to code. You will have to explore the relevant HLTs and psychiatric disorders in this instance for suitable terms, and you will have to use synonyms and consult dictionaries in order to be able to distinguish these concepts. It is also important to check the hierarchy of the selected LLTs, a basic rule that you should always apply when dealing with more difficult verbatims. You may find that LLT argumentativeness would be a suitable coding option, but then realize that it is grouped under PT aggression. And as I said, it is not clearly indicated that our patient here really has an aggressive behavior. Our verbatim may only describe I know it all better attitude. We should not make assumptions and try to be as close to the verbatim as possible. So our final suggestions here are to either code to LLT argumentativeness under PT aggression or one of the other suitable LLTs which we saw before, or to LLT oppositional under PT negativism. And of course, we would also need to capture the refusal of treatment by the patient. Personally, I would prefer LLT oppositional under PT negativism. Somebody who is oppositional rejects the opinion and views of others. It's deliberately opposing rules or norms. So it results in non-conformity, non-compliance. You mentioned this also in the quiz, but doesn't really imply that this person must be aggressive, behaves in an angry or confrontative way. And Jane and I, we had some discussions about this term. Jane, would you like to add something to it?
I coded this term fairly recently, and my first thought was about the argumentativeness. If somebody's rebellious, to me, they're arguing, they are confrontational. But then when I thought about it again, and we spoke, didn't we, Caroline? We spent quite a while on this one. You're right that I think if you rebel against something. So you rebel against some kind of rules or expectations. And so this is where you get your oppositional from, and where our group was suggesting defiant. And I can see that. So I do like defiance, because again, it's fighting against something, whereas the aggression and the argumentativeness is more that it's this provoking it. So no, I agree with you, but it was definitely one of those where I had to look twice at the term, like the pictures we show. This one, yes.
Yeah, it's really difficult to distinguish all these terms. So you would really need to refer to dictionaries and medical references, textbooks, in order to be able to clearly interpret what is available in MEDRA.
Yes. Thank you, Caroline. It's good. No questions on that one from our group either.
Okay. So now we will start with a series of verbatims which relate to a new topic here, procedural terms. Here it is reported that a tenosynovitis stenosans of the right middle and ring finger of a patient was released. So is it again clear what is meant here? Does this describe a procedure or surgery or a medical condition? Or does it describe both, so that we have to consider split coding? Or can we find a combination term that would capture the diagnosis and the procedure? So the verbatim clearly represents a combination term describing an underlying medical condition, the tenosynovitis stenosans, of the right middle and ring finger, and its treatment by surgical release here. Let us first clarify what the term tenosynovitis stenosans actually means. So usually a tendon glides easily through its sheath, but sometimes it gets inflamed and swollen, irritating the tendon's sheath. So long-term irritation of the sheath then can lead to swelling or fibrosis, leading to a stenosing tenosynovitis, impairing the tendon's motion. And on the website of the National Health Service in UK, the stenosing tenosynovitis is considered a synonym for trigger finger. You see it here. Trigger finger is also known as stenosing tenosynovitis. And here the clinical picture, you see here the ring finger is affected. It got stuck in a bent position, and it will straighten with a snap, with a popping or clicking sensation as one moves the finger. The meta term selection points to consider guidance provides some instructions on how to handle similar combination terms. We are first told that terms in SOC surgical and medical procedures should not usually used for coding adverse reactions or adverse events. These terms represent outcomes of adverse reactions, adverse events. And the SOC, surgical and medical procedures, is not multi-axial. So one must be aware of the impact of these terms when it comes to data retrieval, analysis, data presentation, and reporting. So, but if we get such a term and we would like to code it, then if only the procedure is reported, of course, there is no other option. You would code the procedure. We have some examples here. But in our example, in our verbatim, we have a combination term that includes information both about the diagnosis and the related procedure in order to treat this medical condition. And if a procedure is reported with a diagnosis, then the preferred option provided in the points to consider document is to select terms for both the procedure and the diagnosis. You see it here, liver transplantation due to liver injury, you would split code and assign liver transplantation and liver injury, because by selecting a term for the procedure, you are able to really capture the severity of the condition. But of course, you would also have the option to take the alternative approach and code to the medical condition only. We will now browse MEDRA again and search for suitable combination terms. So let me switch back again to the browser. So if I go to surgical and medical procedures, the tendon is a soft tissue, so I would look under HLGT soft tissue therapeutic procedures. Here we have the tendon therapeutic procedures, and here we have several options. More general, tendon operation, tendon graft, tendography, tenotomy, but also tendon sheath incision. And under tendon sheath incision, you will find LLT trigger finger release. So this really seems to be a perfect match based on the definition that we just saw, because trigger finger release can be considered a synonym of tenosynovitis stenosans. So having this trigger finger release would perfectly match what is reported in our verbatim. But now, in order to be on the safe side, let's look for the diagnosis. So the medical condition that was reported here, the tenosynovitis stenosans, and search again. Here it is. Right mouse click, go to browser. And now we are in SOC musculoskeletal, of course. And here is our diagnosis, tenosynovitis stenosans. But what you can see here is that trigger finger is represented by a separate PT. So it's considered a unique medical concept on its own. Well, this is somehow surprising, having looked at the definition we saw before. Let us look at the history of this term. So it was added in a very early version of MEDRA. It was grouped then under PT tenosynovitis. But in version 5.0, it was promoted to PT level and is now represented under tendon disorders. So it's already long ago that this was promoted and considered a separate, a unique medical concept. Now, the principal reference for term interpretation and classification in MEDRA is the door lens. So let's have a look. We may find additional explanations in the door lens in order to understand why the trigger finger is represented as separate PT in MEDRA. And here it is. So door lens defines trigger finger, as already mentioned before, as a finger liable to have a momentary spasmodic arrest or flexion or extension, followed by a snapping into place. But also it specifies that a trigger finger can not only be caused by stenosing tenosynovitis, but also by benign thickening of the flexor tendon, forming nodules. So this is why trigger finger is a separate PT and not grouped under PT tenosynovitis stenosans, because it may have different etiology. Now, would LLT trigger finger release still be a suitable combination term? Well, trigger finger release relates to both underlying pathological conditions. As we just saw in door lens, the stenosing tenosynovitis and the thickening of the tendon, the nodules. Both are treated in the same way, by performing a tendon sheath incision, meaning that this PT does not clearly represent our reported diagnosis. And our reported diagnosis is tenosynovitis stenosans. What can we learn from this example? It nicely demonstrates that it is crucial to be fully clear about the reported medical concept, and that there are regional differences how medical terms are interpreted. It is always advisable to refer to the door lens to better understand the interpretation and classification of medical terms in MEDRA. Also, if you want to submit change requests, it's always advisable to first refer to the door lens in order to see how door lens defines medical terms. And you should always check the MEDRA hierarchy when dealing with more complex terms to ensure that the representation of the reported condition is medically correct. So the PTC document provides guidance on how to handle this type of combination terms, but it may be useful to supplement this guidance in your own internal coding conventions. The correct assignment would be LLT and PT tenosynovitis stenosans and LLT trigger finger release when taking the preferred approach of the PTC guidance. But check if the diagnosis was already captured, either as previous adverse events or as a medical history condition. LLT trigger finger release does not fully capture the concept because it is not exclusively done for treating stenosing tenosynovitis. You may consider this too picky, but it is in line with the MEDRA hierarchy. And remember, trigger finger is represented as an individual medical concept, so separate from PT tenosynovitis stenosans. And you would, of course, also be free to choose the alternative approach and code to the underlying condition only. But whatever you decide to do, whatever your rules will be for handling such terms, document your approach for such terms in your in-house coding conventions to ensure that this type of verbatims is handled consistently. Any questions, Jane? Any comments?
No comments on that one, Carol-Ann. No comments. Hopefully it's clear to everyone. If you've got any questions or comments, or if you disagree with us, please do let us know.
Yeah, we want to make this as interactive as possible in cyberspace. So the next example. Here it is reported that an elective cholecystectomy was performed for chronic cholecystitis with cholelithiasis. When looking at the verbatim, we can say that it is clear and precise. But how can we capture all elements here? Is there a combination term we could use, or do we have to split or prioritize the information that is provided in the verbatim? Which LRT would you select? So select all that apply. Elective surgery, chronic cholecystitis and calculus in gallbladder, cholecystectomy, chronic calculus cholecystitis, or gallstones removal. What would you select? So many of you would, of course, choose cholecystectomy. This is the procedure. And several would split chronic cholecystitis and calculus and gallbladder. Others would select chronic calculus cholecystitis. So we have a split of opinions here. Also, elective surgery and gallstones removal would be an option for some attendees. So here we are. So cholecystectomy, I think this is in agreement, but it's not fully clear how to capture the chronic cholecystitis with cholelithiasis. Now, let us browse Medra again and switch to the browser here. So if I enter chronic and cholecystitis and search, then I have several hits, and you see that we have the chronic calculus cholecystitis here. So this already captures the fact that there are gallstones, that there are calculi. So the chronic calculus cholecystitis would really be useful to select. It would perfectly capture the underlying condition. And of course, in the surgical SOC, if I would go for cholecystectomy, here we are, and search, you will get a nice hit, cholecystectomy, grouped in SOC, surgical and medical procedures. Of course, always, these terms are always uniaxial, have no secondary linkages. So these would be the two terms in our that are reflected in our verbatim. So based on the preferred option in the PTC guidance, we should code to the underlying condition, the chronic calculus cholecystitis, and to LLT cholecystectomy. And when no combination term is available, we would split code based on the PTC document. When raising this split query, we would of course have to clarify whether the underlying condition was already captured. So the correct assignment would be LLT chronic calculus cholecystitis and cholecystectomy based on the PTC guidance if chronic calculus cholecystitis was not captured yet. Some of you have suggested to code to elective surgery because there was no immediate adverse event, no new adverse event or a deterioration of a pre-existing condition leading to this surgery. Handling of PTs like elective procedure or elective surgery is not addressed in the PTC document. Again, you may want to come up with additional internal coding rules if relevant for your product portfolio. So you may come up with such guidance, such rules for your coders, but there is no guidance that is provided in the PTC document. So you can adapt it based on your product portfolio, whatever is suitable for your specific products. Any comments or questions here,
No
Jane?
comments. No comments, Caroline. No comments.
So then I hand it over to you again,
Thank you
Jane.
very much. Thank you. So now we're going to move on to a term called removal of colon mass is the term, removal of colon mass. So again, we always ask ourselves, what is the report actually telling us? Do we have enough information here to code it? Is there a combination we can use that would capture the removal of the mass, the removal and the mass itself? Or do we need to split it? So those are the sort of questions that are going through. I'm sure all of us have these same thoughts. So let's have a look at what we have. Again, we found some terms to give you for you to look at. What do you think about these? Mass excision, large intestine mass, colon neoplasm, large intestine mass and mass excision selected in combination, colon neoplasm selected in combination with tumor excision, or would you seek clarification from the reporter? And if you've forgotten what the report was, Caroline's put it in the chat for us, as we do with all of these examples. So what do you think here? I see a few of you have voted. What would you choose here? Would you go for the mass excision? Is that enough to capture it? Large intestine mass or colon neoplasm, which captures the site of the colon? Which of those is the most appropriate, or a combination? Oh, I think that's about stable. Anyone else going to vote? So see where you voted. So by far the largest selection was large intestine mass and mass excision. So you're sticking with the mass. I couldn't tempt anybody to colon neoplasm there. Only a couple of you there with the excision of the tumor excision. So what have we got? We've got a mass. What is a mass? So let's have a look in the browser and see. Where are the masses grouped in the browser? I'll clear the selection from where I was previously. And let's have a look at what mass terms we have. Colon mass? Any luck on colon mass? No. So let's think of a synonym for colon. Intestine was the term we had. I'll just put it as intestine so that it captures intestinal or intestine. Intestinal mass or large intestine mass. So large intestine mass sounds like, well, that would capture there's nothing there in my list that came up with excision with large intestine, but if I am needing to split, large intestine mass seems like a good one with a PT of intestinal mass, and we can have a look at the hierarchy for that one. It goes to gastrointestinal disorders. It doesn't go in with the neoplasms. So I think what we're seeing here, and we can have a look again with the mass, let's have a look for the mass excision. If we're going to split it, perhaps we'll look, as most of you suggested doing, mass excision, select that as a separate PT, mass excision, therapeutic procedures as a mass excision. So I would say that a mass is not a neoplasm. I would not code a mass to a neoplasm because a mass could be a number of things. It could be a cyst. It could be a lot of things, not necessarily a neoplasm. So I wouldn't choose a colon neoplasm. I would look for the closest mass term. I could choose mass excision because that is what's being reported, but we lose so much clinical information there by losing the site. So this is where my thoughts would be thinking at this stage. So let's go back to our slides. And again, going to the points to consider, we've already mentioned this once today. When you do split, sometimes you capture more clinical information. And here are the examples that are given us in the PTC document. And I think this is one of them. Colon mass excision, colon mass removal. It captures more. It tells us the site of the mass. So I think it is worth splitting. And overall, I would look to split. So firstly, I'd look at to refer to my own internal coding conventions. You might have conventions around the handling of masses and neoplasms and lumps and tumours and all of that. Have a look in MEDRA for a combination term. I didn't know if I was going to find an intestinal mass removal or excision, but there wasn't one. And then looking at the PTC document, I decided to split, and I had to use synonyms. And you saw me do that looking for intestine rather than colon. And just a note there that one comment we had this morning was when you see a large intestine mass, it refers to the large intestine, i.e. the colon or cecum or rectum, rather than saying it's a large mass. So just a note there in case any of you are also confused on that one. When we see large intestine, we take it as the colon, the cecum or the rectum. And we confirmed that this morning in the concept descriptions in the browser. So overall, I would split code that one. I would select large intestine mass with a PT of intestinal mass and the LLT of mass excision. So that was our final thoughts on that one. Any thoughts, Caroline, on that one?
No, no comments, no questions for this verbatim, Jane.
Thank you. So we've got another one now. Thank you, Caroline. This is another excision. This is a benign pigmented mole from the back. So what they're telling us here, it's another excision, isn't it, of a mole this time. So skin on the back. Can we capture everything here? Can we capture the fact it's benign, it's pigmented, it's been excised? And is there a combination, or do we need to split again? The same questions that we ask each time. So here I'll go to the browser straight off and I'll look for my benign pigmented mole, wasn't it? Well, let's have a look under benign and pigmented. And we see, so we come up, there isn't something with mole, but there are two terms that actually capture the excision, a benign pigmented nevus excision. So benign pigmented nevus is under a PT of skin neoplasm excision. So if I go there, go to the browser, we can have a look here. It's a skin neoplasm excision as a surgical medical procedure, and it's got almost identical to what I need, benign pigmented nevus excision. Now, I would have a look and see, is a mole and a nevus the same thing? I would look in my references to check to be sure, is it the same thing? I can have a look in where is mole or mole excision, because it tells us it's a benign pigmented mole. So we can have a look in MEDRA at mole excision. There is an LLT for mole excision. And this one has a PT of mole excision, so slightly more specific at the PT, but it doesn't capture everything at the LLT level. So that's another, and that's a skin lesions excision. So if we go back to where we were, or let's take this one and go to this one, go to the browser. It'll bring us down. So the HLT there is skin lesion excisions. That's the name of the HLT. And when I click on that one, I can see there I've got mole excision as a PT, skin lesion removal, skin neoplasm excision. So it's a separate PT. So is a mole and a nevus the same thing? Benign pigmented nevus? I think so. And I would do some research to check it out, but I would check that they were. And if we have a look at mole, just general mole, how's that classified in the terminology in MEDRA? We can have a look for mole. Mole excision, mole of skin. Let's have a look at the placement of this one. Melanocytic nevus, there it is. So that confirms I'm quite happy with that then, that MEDRA treats nevus and mole as synonyms, because look, I've come across here to the browser on the left. It's jumping about a bit today, I'm sorry. PT, melanocytic nevus, so meaning pigmented, and there's the mole underneath. So mole is a nevus. So I'm quite happy there with that, my choice. So let's go back to our slides. again, just a reminder, one thing to point out here, though, that I didn't show you in the browser, when you look at them, you find the benign pigmented nevus excision is the LLT, and it's under the PT of skin neoplasm excision. But one thing we noticed is if you look at the PT, you lose the benign, you lose the histology at the PT level. So this might be something to bear in mind, depending on why you're coding, what's the context of your study, and what's important to you. For retrieval, when you do analysis on your data, you might want to consider that you may want to choose a second term to capture the histology. So I would use a browser to find a procedural term capturing the underlying disorder and the surgical intervention. That's always our first option. That's our ideal. Find a combination term if one exists. But I did check the hierarchy here, and it may be that if you do have any internal data retrieval requirements, it might be important to you to capture the benign. And then if it is a condition of interest, you might have a guideline which suggests that you do split code to capture that. Final suggestion there was the LLT of benign pigmented nevus excision, just as a summary. Okay, any thoughts, Caroline? Any comments come in from our group about that one? Did anyone disagree?
No comment from the group, but I would like to emphasize that you could see that the LLTs refer to benign conditions, so benign nevus, but also to rodent ulcer, malignant neoplasm excision of the skin. So it's really important to realize that the histology, and this is really very important medical information, in the surgical SOC may only be represented on LLT level under more vague PTs, more general PTs. Yeah. So if you would like to then search for benign or malignant condition, you would need to refer to the LLT level. You see skin malignant melanoma excision or skin squamous cell carcinoma surgery. So this is important information, and this is not reflected in the PT name, skin neoplasm excision.
So it's something to bear in mind when we say to people, check the hierarchy when they do select an LLT, and this is one of the reasons why it may be important to capture that, particularly if the skin cancer hadn't been captured, if it's a clinical trial or it hadn't been captured elsewhere, you may want to make sure that the skin cancer has been captured if it was a malignant, mole or lesion that you were removing here.
It's really dependent on the relevance of this topic for your products, and if it's relevant, that it would really need coding conventions in order to make clear how to handle such terms.
Thank you, Caroline. Yeah, good point there. Thank you. So then my next example is a resection of a saphenous vein for coronary bypass surgery. So what do we have here? What is this procedure? Are we clear? Well, they're resecting or removing part of the saphenous vein, and it's for a bypass surgery. So it's going to be inserted for coronary bypass. Is this one operation? Are they doing this together? Or then do we need to capture the bypass as well as the vein resection? What's actually being reported here is the resection of the vein. So what about the coronary bypass? Or is it all one operation? So what do you think? What, if you've got your browser open, what LLT would you select, or LLTs for this one? Venous surgery, that's quite a general start, isn't it? Coronary artery bypass graft, capturing the procedure there, cabbage. Vessel harvesting, yeah, vessel harvesting, and part of the procedure, isn't it? Coronary artery bypass. Coronary artery bypass graft, to separate those two as both LLTs. Vessel harvesting and coronary bypass. Saphenectomy, another thought there, slightly more specific in the location of the vein being removed. Coronary artery bypass graft. Saphenectomy and coronary bypass graft, you'd code them both. So we see where we've got some consensus, I think, among us about the coronary artery bypass graft, and then a bit of difference in how do we capture, whether we capture it separately or not. So let's have a look. So I did a Google search to see what came up with, and I found this on PubMed. saying that I wanted to check out for myself that the saphenous vein is one that is used in coronary artery bypass graft. And yes, it is. I don't have that technical in-depth knowledge to know exactly which veins are currently used. And I found that yes, it is. So it is one that is the vein or part of the vein would be removed for use as a graft. So that was my first bit of research. And then I found, what does the operation consist of? Is it one operation? So yes, they remove the vein and enter it into the coronary circulation at the same time, as it were. So it is one operation. So in a way, you could say that the removal of the vein is part of the coronary artery bypass surgery. And it says there that saphenous vein is one that's commonly used, as well as sometimes the radial artery from the arm. So we can have a look in Medra. Let's go and browse and see what we can find. Well, obviously we've got our coronary artery bypass. We could capture. Let's have a look for that one. That's what's been reported. Coronary artery bypass or coronary artery bypass graft, 2 LLTs linking to the same PT. Well, that certainly I would be looking to capture that. I would check and see, had that already been captured? Is this report here only referring to the vessel harvesting that you mentioned? Or is this the only mention we have of the whole procedure, in which case we're looking for the coronary artery bypass, we'd need to capture it. And when we look at the LLTs, there is some specificity there. If you knew that it was multiple vessels or quadruple vessel bypass, you've got the options there at the LLT level under coronary artery bypass. But I'd be looking for one of these terms to capture the operation. And then we've got our saphenectomy or phlebectomy, saphenectomy, oh, spell it right, saphenectomy, removal of the saphenous vein. That's a possibility. I think some of you said that, and that has a PT of phlebectomy, although that's, I know that that is sometimes used also as a treatment for varicose veins, but a saphenectomy is removal of the saphenous vein, a resection. So there it is, saphenectomy. So that's, that is a potential one to capture the specificity of the vein that was removed. The other one you gave me was vessel harvesting. We can have a look at that one. Vessel harvesting, there it is. Vessel harvesting is the PT as well. And that's a procedure under vascular therapeutic procedures. What I like about that one is it does link it to the main procedure. It talks about harvesting, that you're doing it in preparation to use it, the vein elsewhere. So I like that. But what I'm not so keen is it is more specific. It doesn't tell us the vessel that's been removed, just vessel harvesting. So I think that is an option when we do our coding. I like saphenectomy because of the specificity of the site, but vessel harvesting has the advantage of linking it to the procedure. So let's go back. I'm not being very specific, am I? So learning points here is I would look at my medical references to make sure that I fully understand the surgery and to check whether procedures are conducted concurrently. I'm sure this is something we've all done in our coding career, to check when you have a whole list of procedures reported together and you need to understand, was this one operation or was this separate? And in clinical trials, you might be asking the investigator to split, and they're not always keen because they say, well, it was one operation. It's difficult to code when it's like that. And I would check in this case whether the bypass surgery had already been reported and coded separately. And I would look if this was an area of interest, I would look and see whether we had any internal coding conventions. It may be that when these common procedures that are reported together, you have a convention so that you get consistency. And Carol Ann suggested a couple of examples for us, the same, and reminded me, cataract extraction and insertion of intraocular lens. That's probably one that we've all grappled with over time. Where do you put that? Which bit of it do you capture? So this is another example, the removal of the vein for the bypass. Which one do you code it to? Another one, angioplasty with stent insertion, another one that's often reported together. And I know that when I used to work in the industry, we had guidelines for that, according to the stent insertion. So let's good thoughts there. Think about your internal conventions. So overall, I would say if the bypass surgery hasn't been reported separately, I would select coronary artery bypass graft, and just note that there are other LLTs available for multiple grafts if needed. And if the bypass surgery has already been reported here, there we are therefore definitely looking at capturing the fact that the vein was removed for the purpose. So it's either saphenectomy, which has the specificity of the site, or vessel harvesting, which gives us the fact link to the bypass. Do you have any comments on that one, Caroline? Anything you want to add?
Nothing to add from my side, and we don't have any questions, so we have a silent audience this afternoon. Maybe it's too late for some of the participants in Russia and in Europe.
Maybe. But I remember when we had this conversation, Caroline, you said the same, that this was something that you would have had coding conventions for, didn't you, in your past organization?
Yes. We really then only coded the major surgery, so coronary bypass surgery, bypass graft surgery, or cataract extraction, or coronary stent insertion, for instance. We did not split.
Good, thank you. So that was the end of the ones that I had. I'll pass it back to you, and we'll see if we can. I just having a look at.
We have a nice comment from Kerstin. Your explanations are just so well presented, it's hard to disagree. So there are no comments from Kerstin for that reason.
Thank you. That's nice. So I'll hand back to you, Caroline. We've got 10 minutes, so we can fit probably at least one in here. And then...
Thank you, Jane. So here we are. So now our next verbatim is spinal fusion is reported now. So do we know whether this verbatim describes a condition or procedure? And is there closely matching suitable LLT that is available in MEDRA? And is there closely matching, if there is no closely matching LLT, do we need to query? So what to do with this verbatim?
We've got
again, we have the same problem with the Paul, obviously.
Try and clear the responses, Caroline. If you go to the top right-hand side, you can clear the responses. That's it. And then we'll be able to read. Is it perfect?
Yeah. Okay. Here we have the first responses. Query. Another participant would code to spinal fusion. Query to clarify procedure versus condition. Go to the exact match. Spinal fusion. Yeah, there is an exact match in MEDRA for spinal fusion. So the vast majority really votes for spinal fusion here. So thank you for your proposals. So when searching for spinal fusion, you will see that this term usually relates to a surgical procedure, the fusion of vertebrae, an operative immobilization of two or more vertebrae, as you can see here on this image. But it may also describe a medical condition, so either an acquired condition that can be seen in diseases like ankylosing spondylitis, for instance, or also a congenital fusion of the vertebrae that is shown on the second image here, congenital fusion. This clearly shows that spinal fusion is an ambiguous term. So I will now search for spinal fusion in the browser. Here we are. I will enter spine to capture spine in spinal and fusion. Search. And we'll search. And here we are. Here we have a direct match, spinal fusion. And if I click on it and go to the browser, here we are, then you can see that spinal fusion or spinal fusion NOS is grouped under spinal fusion surgery, So these are more general terms that are grouped under PT, under surgery term in surgical and medical procedures SOC. This is because in most instances, spinal fusion is referring to a surgery. Also, when you look at Dorlans, let me show you and log in here in Dorlans. If I enter spinal fusion, I told you that the Dorlans is really, what is happening here? Dorlans is the primary reference for MEDRA, for the interpretation of MEDRA, of medical terms and classification. So here we are, spinal fusion, operative immobilization or ankylosis of 2 or more vertebrae. So here it's clearly considered a surgical intervention, the spinal fusion. So this is how it is also represented in MEDRA. So it captures the medical concept, but of course, reporting practices do not always follow the definitions in MEDRA or the definitions provided in Dorlans. So we don't know whether this spinal fusion really relates to a fusion surgery or whether it relates to an acquired or congenital condition. It is not made clear by the verbatim. So let me switch back to my slides. Here are our learning points for this verbatim. So first we will have to explore MEDRA to better understand the reported medical concept. We saw that there are terms for congenital spinal fusion, for acquired spinal fusion, and also a PT for spinal fusion surgery. We will have to consult medical textbooks and reliable internet references in order to better understand the reported concept. And if you then find that this given medical term is ambiguous, then you would need to seek clarification from the reporter. Because as I mentioned, even though spinal fusion, LLT spinal fusion or spinal fusion NOS is grouped under PT spinal fusion surgery, this does not mean that reporting practice really follows the MEDRA classification or the definition in Dorlans. So it may not relate to a procedure what is reported here. So the final suggestion for this verbatim is to query the term and to ask whether the reported event describes a surgical procedure, a congenital, or an acquired condition, because it cannot be coded with what we have here. We should, and you saw that these more general terms, vague terms, are grouped under a surgery term. So if you are using an autoencoder to support coding in your organization, it may really be helpful to avoid autoencoding of similar ambiguous or also very vague MEDRA terms, like, for instance, LLT and PT infarction or LLT and PT necrosis, by compiling a list of always query terms, or as we called it in my previous company, blocked term list. So to exclude these terms from autoencoding in your coding process. So there are some terms in MEDRA that really are more vague and are grouped under more specific PTs based on medical definitions, based on usual reporting practice, but this doesn't mean that this can be applied in all cases, in all instances. So in some instances, it's really better to avoid autoencoding of such terms.
And so we've got an interesting comment there, Caroline, about if it's in MEDRA and it's ambiguous, shouldn't it be made non-current to avoid the autoencoding?
Well, MEDRA is following the Dorlans here, and it's really following, in most instances, spinal fusion, if you look into literature, really refers to surgeries. And in order to capture the concept MEDRA has made the definition, the decision to include this term in the terminology. But you as a coder, you should always check the hierarchy in order to ensure yourself that the hierarchy really reflects what has been reported. That's one of the lessons learned from this verbatim here. This is really a basic rule that you should always check the hierarchy for more complex terms in order to ensure yourself that the PT also reflects what is being reported in the verbatim.
Yes, it wouldn't surprise me if it was to be made non-current at some point, because it is ambiguous. But as you say, they've placed it there. It's not at the PT level, and it captures that.
It's difficult because, as I mentioned before, there are really regional differences in the interpretation of terms. Like heart attack, for example. In English, it's always referring or describing a myocardial infarction. In German, Herzattacke would be the term in German, may not relate to a myocardial infarction. So there are always regional differences also in the interpretation, in the classification of terms, and therefore it is really necessary for MEDRA to have a primary reference to classify terms, and this is the door lens. And if the door lens says that spinal fusion is considered a surgical term, then MEDRA would follow this definition and classify this as such.
Yes.
Yeah.
See, there's no more comments on that one, Caroline. Just thank you for your positive feedback. Those of you that are giving us positive comments, that's nice to know that you found the session useful. So I'll take it back, and we will.
Yep.
We'll
Thank you,
look at the end of just the last couple of slides just to wrap up. Well, we've been doing this session monthly now since November of last year, and we've been recording them and putting them on YouTube. So if you have joined us today and you've enjoyed it, then the sessions are available for you. You can dip in and out, so it's not so intense listening to us in one block. And if you do go to the YouTube channel, we've got our playlist for Let's Code Together. And you can also see, if you look there underneath the picture where it says here, the verbatim terms so if you click here, if you open a session and you look underneath it, the verbatim terms for each session are provided in the description. So if there's a topic that you're particularly interested in, you can have a look and you can decide whether you want to view that session or not, which one you want to view. We had comments this morning. Somebody was asking us for pregnancy exposure to drug during pregnancy. And this is something that we spent quite a bit of time on in an earlier session. So we're able to point them to the session that lists them. So if you have a look there, so that's just a comment for you. We are still wanting to keep it as useful as possible for you. So we have a survey here. It should come up on your poll everywhere. Hopefully it'll come up on your voting that we can see. Let me just make sure and activate it. Has anyone? We used it this morning. It says it's active. So please do tell us what you think of the session. Tell us how we can improve, what you've enjoyed. And this is also your opportunity. If there's particular topics that you'd like us to address, you can let us know here in the poll, in the survey. And if you have actual verbatim terms, do let us know, and we'll put them on our list and we'll look to include them in a future session. Can't promise when, but hopefully it helps us by getting real life examples. So I think that was everything we wanted to say today. We thank you very much for your attention and for your interaction during the session. It makes it much more enjoyable for us all with the questions and the comments you make. So anything else to add, Caroline?
Nothing to add other than saying goodbye and thank you.
Thank you, everyone. Stay safe, everyone. Stay safe. Bye-bye.
Bye-bye for now.
Bye-bye.